Alright, let's get straight into this. NDIS Minister Stuart Robert defends governance of disability agency after a series of controversies. Robert says he has absolute confidence in NDIA Chief Executive Martin Hoffman after social media posts. Stuart Robert has defended the governance of the National Disability Insurance Agency, but refuses to sign up to more ambitious targets to get younger people out of aged care in an outing in the National Press Club on Thursday. The Minister for the NDIS and Government Services declared absolute confidence in the agency's Chief Executive Martin Hoffman despite controversial social media posts, and revealed the global law firm Ashurst had conducted an investigation and found no clear privacy breaches in NDIA Chair Helen Nugent's reported use of her Macquarie Bank email for NDIS business. On Thursday, The Australian reported that Hoffman was a New South Wales and federal public servant. He had praised Scott Morrison on Twitter and retweeted Donald Trump and comments attacking the militant construction union. Hoffman has denied being an anti-union Trump supporter and deleted his account. Robert said Hoffman had posted the material before he became a chief executive, and he enjoys the freedom of speech that everyone else here enjoys. I absolutely and utterly reject any assertion that he is not a public servant of the highest caliber, Robert said. He enjoys my absolute confidence. Side note, your confidence ain't worth shit, mate. Continuing, Robert appeared at the press club to launch the latest NDIS quarterly report, but was grilled on topics ranging from extensive redactions of NDIS data from Freedom of Information responses to the legality of the robo-debt program. The report paints a picture of an improving system with 114,000 participants added to the scheme and a total of 310 now receiving support. Robert told reporters the disability workforce would have to add an extra 90,000 workers to cope with projected increased demand. He foreshadowed future reforms, including the national rollout of independent functional assessment, greater flexibility of funded support, and greater data sharing with disability and research groups, whatever that means. Robert said between March 2017 and June 2019, the number of young people in residential aged care has decreased by 11%, from 6,287 to 5,606. Alright, some quick math for you everybody. That's a decrease of 681. So I can see why they went with percentage, because that does look more impressive than the raw number. Continuing, the number of young people entering residential aged care also decreased by 22%, from 536 new entries in June quarter of 2017 to 416 in June quarter of 2019, he said. Alright, pause the article there. What the fuck does that mean? We'll just table the fact that he just admitted that the amount they've managed to get out is not much more than how many enter in a quarter of a year. We'll just table that for a moment. Because if you decreased how many are going in by your whole 22%, that's 2 years. Now, these numbers quarterly, so that's how many new entries each quarter. Deliberately confusing. I'm not sure what they mean, but we'll go with that. We'll go with every quarter they get an X number in. One quarter 2 years ago was 536, and then every quarter they'd have another reported number, and that would go down until the latest one. So we'll be generous and we'll give them the bottom number for the whole 2 years. So that's 2 years, 8 quarters times 416 gets you 3,328. Now, even if I've got that all wrong, like the number is the amount over the year and they're reporting it in June, that's still, 536 plus 416 gets you 952, and then we got to add June 2018, so we'll chuck the middle number in between those two. 476 gets around 1,428. So no matter how it's done, it's not a good look to be like, we've decreased it, maybe not even half of how many have entered. Back to the article. The Aged Care Royal Commission Intimate Report recommended the government commit that no more younger people should enter aged care by 2022, and all younger people in care should be out by 2025, subject to limited exemptions. Robert said, "I want to do a lot more," but he was still considering if it was appropriate and possible to do more. "It requires a huge number of houses to be built, providers to be identified, and to be able to provide support. So lots of things have to work together, but we are absolutely committed to looking at it." See? They're committed to looking at it. In response to a question about the Saturday paper's report that 2 years Nugent's conducted business relating to the 22 billion NDIS from an email server belonging to Macquarie Bank, Robert revealed that he had asked for an independent review. The Ashurst review found no clear breaches of privacy, but recommended that the Disability Agency demonstrate that no further emails would be sent to personal addresses. Robert said broad minutes had been sent to the personal emails of non-executive directors since the inception of the scheme under Labor in 2013. "I'm not satisfied with the practice, and to ensure the highest level of probability concerning NDIS emails, the departmental secretary will get back to me by mid-November to assure me those actions have been undertaken." I'm sure it made more sense when he was saying it, I guess. Asked about extensive redactions from an ABC Freedom of Information request about waiting times for NDIS plans, Robert responded by claiming material from his incoming ministerial briefs had been excluded by the terms of the own reporter's requests. Wow. Robert then produced a printed copy of the quarterly report claiming that it has every piece of data you could possibly want. Robert was asked about a former senior administrative appeals tribunal member, Terry Carney, contention that the robo-debts are unlawful, and 2 high-profile cases in May and September when Centrelink waived the debts rather than drop the case. At first, Robert refused to answer because the question did not relate to the NDIS, but then defended the legality of the robo-debt by arguing the system of averaging as the bias to say to a citizen, "There may be a debt, please engage with us," was entirely appropriate. As Australians engage with us and provide information to us many times, they can actually prove that they didn't earn too much, and in fact 19.9% of cases, Australians, when they engage with us, actually demonstrate through their bank account records or salary pay slips that they don't have a debt. Alright, there is so much to say about this. We probably won't even cover it all, but I guess we'll start from the bottom and work our way up. The fact that 19.9% have come forward and actually proven it, that only says to me that there are more of them that shouldn't be paying a debt but don't have the means to prove it, because I've seen what some of the requests are and it's ridiculous. Some places you just can't get this information. And goes to the broader case of why is the burden of proof on the person? Just go fuck yourself. Come on. And then to the even broader case of why does somebody need a job and government benefits? Because what that tells me is if you're going to Centrelink because your job isn't paying you enough to get by, and Centrelink is okaying the fact that they need to give you extra money on top of your income, the government is okaying employers to poorly pay their employees. They are subsidizing the missing wages. If you want to save money on government benefits, maybe make places pay the people properly. Oh, but you can't do that, because then why would you have a reason to send out these robo-debts? But that's not what we're here for. What we're here for is what that little math session was all about, and the first paragraph of the article on how Stuart Roberts refuses to sign up to more ambitious targets to get younger people out of aged care. Now, here in Australia, the aged care system is a shit show for its aimed demographic of the elderly. Even just left to that, they can't do it right. So then chucking people that are younger with mental health and disabilities on top obviously isn't going to help. And all of this reminded me of two articles I read ages ago. So I dug them up and we're going to go through them because I think they explain why there's an issue with younger people in aged care facilities in the first place. Alright, this one is from The Conversation from 2015, titled From Asylums to GP Clinics, the Missing Middle in Mental Health Care. Quizzed in Parliament recently about what the government was doing with the National Mental Health Commission's review into mental health services, Health Minister Susan Ley said she would be making strong statements about mental health before the end of this year. Let's hope so. There were 32 reports and inquiries into mental health between 2006 and 2012 alone. The common finding includes from the Mental Health Commission, which released its report in April, is the categorisation of Australia's mental health system is in crisis. One key reason for this is the missing middle. Most of Australia's asylums were closed in the 1990s, though the Australian Institute of Health and Welfare reports there are still 1,831 acute to subacute beds operating in specialist psychiatric hospitals as opposed to general hospitals, costing more than $500 million annually. It is widely accepted that on closing the asylums, Australia failed to invest in an alternative model for community mental health care. This means that for people seeking mental health assistance, there are few alternatives between the GP surgery and the hospital emergency department. These alternatives reflect the financial ramification between the federal government, which pays for primary care, and the states and territories which manage hospitals. Nobody currently owns or has responsibility for community mental health services. The federal government has been ramping up investments in primary mental health care. This has been principally through the Better Access program, now costing taxpayers more than $15 million per week, mostly in payments to psychologists. Apart from a small sample of selected customers in 2010, we know little about the merit of this spending, other than it has continuously increased since the program was introduced in November 2006. In relation to hospitals, cost increase but rate of access to care does not. People often refer to the grim term the revolving door. When people are admitted with acute symptoms of mental illness and are at risk of harm to themselves or others, they are commonly stabilized, provided with some medication, and then discharged with little or no ongoing community support. They can become unwell again quickly and then need re-administration. Connections to community services within a week of discharge vary widely depending on where you live. In Victoria, this connection is made in around 72% of in mental health hospital discharges. In New South Wales, it's only around 48%, which is almost exactly the national average. It is this middle ground of community support that is missing in Australia's approach to mental health care. But what exactly does this look like? A new approach would have had much greater roles for a range of mostly non-government organisations which over many decades have built deep skills in provision of psychosocial support, living skills, housing and employment support, increasingly mixed with specialists and even clinical skills. These organisations receive only around 7% of Australia's mental health budget. Another element of contemporary community mental health is step-up/step down services. These generally provide a short-term support accommodation options to either prevent further escalation of a problem and hospitalisation or smooth transition to home following discharge. They are not overflow wards from acute care. There would also be much greater involvement from multidisciplinary communities, mental health teams operating from the high street, not the hospital campus. Such teams are multidisciplinary, comprised of social workers, psychologists, peer workers, occupational therapists, nurses, and medical professionals. These teams provide assessment, treatment, case management, and support services to people with a mental illness. They could also have a capacity to assist and respond to crisis. Ironically, such teams did exist in Australia 15 years ago, but have been largely dismantled. Community mental health nurse outreach service would add considerable capacity to the system, as already proven by the success of the mental health nurse incentive program. This program is currently tiny, however costs just over $40 million a year. Peer workers would also be a much greater element in our service system, ensuring our scarce and valuable professional staff can work to the top of their practice. There are programs such as personal helpers and mentors and partners in recovery which aim to help fill the void in community care, but these now look likely to become restricted to recipients of support under the National Disability Insurance Scheme. With community mental health falling between federal and state governments, there is a lack of leadership to assess the problem. Despite this, I am aware of at least 4 approaches being taken to fill the missing middle. A large metropolitan hospital, keenly aware that the existing revolving door approach is unsustainable and will result in poorer care. It established a new relationship with its partners in the community to keep people well. New South Wales government has introduced a social impact bond, a new mechanism to finance innovative alternatives to hospitalisation. A new primary healthcare network has similarly concluded that the current funding and service system is inefficient, wasteful, and creates duplications and providers disintegrated care. That is exploring pooling existing funds to create new approaches. A regional health district has invested considerable resources in establishing new collaborative forums to engage the community sector in a dialogue about better organising mental health care in the community. There are differences between these approaches, but they all share some characteristics. They are born from frustration with existing policy and funding approaches, which are viewed as inadequate, soiled and unsustainable. They seek to create local solutions and not rely on any central government planning or intervention. What they also reveal is that despite of our leadership vacuum 20 years after the asylums closed, people working in the system recognise the situation's too serious to wait any longer. Do you see the connection I'm trying to make between these two articles? There was an increasing number of younger people ending up in aged care facilities, and that's coming on the tail end of widespread closure of quote-unquote asylums. Now, to one of my first videos again, where I detail my experience I had at the NDIS Expo I went to in the week I made that video, and I said to the panel, are they aware that there's lots of articles about how people are falling through the cracks because of the lack of mental illness care in the NDIS? My main concern was people looking for help in a place that can't supply it. So to help the people, better direct them to where they can find the help, which then brings us back to the articles we've just gone through, where I wasn't really aware that there is nowhere to send people to receive the help that they need. Now I can see why the old school asylums were closed down if they were just poorly run and mismanaged and abuse, poor treatment of people, but you couldn't just close down something and then go, alright, off you go. Where are they going to go? They go back to the families that can't cope. They end up on the streets. They end up in prison. They end up in emergency rooms, and they end up dead. Because really, the aged care facilities are where the ones that can afford it end up. Alright, now I can see how there be arguments for and against having funding for all of this under the same umbrella department or something, like mental health, disability, all that. But if you used to house everyone together, why can't we fund everyone together? Because here's my final point before I go through the next article. What is a mental disability versus a mental illness? These terms we use, it could maybe spark something that you think of and you think you might know a solid difference, but it's not like you have to be born with a physical disability. You could have something amputated and become differently abled further on in your life. Who's to say the same thing is not happening mentally? It does happen mentally. Old age. Back to the aging facilities. They have institutions for places for people that need this care, but just not specialised enough where it's like, okay, we can chuck things in the mental health basket like depression and post-traumatic stress, things that we're familiar with in that sense. But what would you classify schizophrenia as? It'd be a lifelong quote-unquote disorder. People were born with it. It can be triggered by things like it can be awake or not active in a person, and they don't really know the cause. And when I hear people talk about it, it usually goes more towards the mental illness direction. But what's an illness? Isn't an illness something that you can cure or have treatment for? What's a disorder? What's a disability? Because autism also something they're not too sure of the cause of, have it from birth and have it for your lifetime. Rarely these days you're going to hear someone talk about that in a mental illness context. It might just be from my personal experience with like my brother's specialists and stuff. That's when people were using the language like disability. And now, final article. Better care a must for mentally ill, from January 2011. You would not close down public hospitals, leaving it to communities to heal the sick, mend the broken limbs, perform open heart surgery, or do a lung transplant, would you? Neither would you send them to DOS houses or jail. Yet this is what has long been happening to a section of our community, the sick of mind, the mentally ill. Some decades ago, the closing down of mental hospitals and psychiatric wards were deliberately initiated. The lofty theory was that from then on, those people with a psychiatric illness would have been taken care of by a loving, caring community run by loving state or local health bodies. Thousands were put into boarding homes, halfway houses, and into health benefits which would pay for them and their lodgings at those establishments. This then allowed open slather on the unfortunate mentally ill. It was also thought that, like magic, the mentally ill sufferers would somehow be absorbed and possibly even cured. The reality is they end up in our jails or disappeared into the land of the forgotten. Some of those you might get a glimpse of when visiting the cop shop, their mugshots pinned on the wall. The problem with those suffering from mental illness such as schizophrenia or the preferred tag of bipolar is that the symptoms of mental illness are not always so benign as not to need more than just a packet of tablets, a pat on the back, and a bed to sleep in, or a meal on their plates. I know because my brother Frank has suffered from chronic schizophrenia his whole life. Soon after my parents immigrated here in 1956, my brother Frank's behaviour became increasingly difficult. My parents were no longer able to manage his violent outbursts. Scissors ended up sticking in my brother John's side. He was subsequently diagnosed as a sufferer from schizophrenia and hospitalised at Callan Park Mental Hospital, Sydney. His many years in and out of this hospital were a nightmare that continued to traumatise our family relentlessly. A true Bellam situation, if there ever was one. Has the situation after all those years changed? Nothing would have pleased my parents more than to have had their son living with them. This was just not possible with 5 other younger siblings to look after. Frank's attempted suicide jump from Iron Cove Bridge, Sydney, was the final straw. He was, thanks to the Dutch government, repatriated back to the Netherlands, where he has lived ever since. His care is excellent, which we can only dream about here in Australia. But more importantly, Frank is alive. I doubt this would have been the case if he had stayed here. The idea that the mentally ill would have been taken care of without any professional, well-run facilities or expert care was never a sound idea and was probably based on saving money than care for the mentally ill. They often end up in jail for no reason other than they are ill and cannot find the expert help they need. It is estimated that 80% of the incarcerated are suffering from mental disease. When judges are confronted by cases of violence or even homicide and the offenders are mentally ill, their only reluctant choice is for a jail sentence. Our expenditure on mental health is much lower than other compatible countries. No matter who's in power, Libs or Labour, our mentally ill sons and daughters are the forgotten Australians. Year after year, if not in jail, they will end up wandering the streets, dishevelled, unbuttoned and unkept, with their physical health as bad as their mental state. I have never heard of people needing heart surgery or broken limbs ending up wandering the streets, or worse, being sent to jail. Why is it so often that is the case for the mentally ill? There's a dearth of information that it is not only jails that are being swamped by mentally ill. The emergency departments of hospitals are also overloaded on a daily basis with people with psychiatric problems who have no alternatives. My brother Frank is a lot calmer now. He is in his own room with TV, enabling him to watch his beloved soccer. He receives good medical care, including regular dental checkups, aged care, and most importantly, his medication is supervised. He receives his full sickness benefits, which he can use as he sees fit. He enjoys regular holidays and visited my parents, accompanied by a caring, well-trained staff when they were still alive. I can phone Frank up and receive regular updates from expert psychiatrists and doctors. It costs money, but so does our love for wars fought in faraway countries. While some Australians have lost their lives in Afghanistan and Iraq, I bet far more lives are lost on our streets by the government's lack of care for our mentally ill. Well, there you have it. They closed down the psychiatric hospitals. They're going to kick them out of aged care facilities. They want to close down special schools. Mate, someone needs to let the government know that people with disabilities and mental illness don't just go away, and refusing to give proper care is A, cruel, B, further strain on the economy, because then you're just going to pick it up in other places like hospitals and jail cells. And a quick little side note about language and words that people use, because words are really important to me, and I don't like the terms not a big fan of mentally ill, because illness makes you think sick, makes you think, needs to be cured. And then the things they try to categorize as that you can't simply cure. And then disability, where it's to whose standard, what are we judging this on? But just as, if not more so important than the word itself, is obviously always intent, where if you're using it to be abusive or as a slur, or to attack someone, look down at them, or act like they're less than, that matters a lot more. Because that's why there's been probably so many terms that started off as just a word that people used to describe something, and then it was twisted into a abusive tag. Example, the company Minder. And the way I see it, this is probably because of growing up with my brother, where I didn't see an issue. I understood he was different to my mates, brothers and sisters, but they always were fighting. We never fought about anything, so why would you want to fight all the time? And despite people acting like we're doing something extraordinary, or probably even the reason for a response I would give to some of these people, God bless when it's coming from a good place, but it gets exhausting. Oh, how do you do it? Would you stop caring about your best friend if they were depressed? Would you cut off your uncle because he got cancer? No, you wouldn't. So, and that's a good segue to my final point. Maybe because of my brother, maybe just because of the way the world is. I always saw it as everybody needs help. At some stage, in some way, one way or another, we all need help to varying degrees in varying ways. So we work together to facilitate it all. Kind of like what already happens. Because you might see it as you just go out and buy some coffee, but I kind of see it as there were probably thousands of people involved in helping me to achieve this cup of coffee. Because I'll be damned if I'm growing my own coffee beans and processing it all. It's a bigger picture. And so I figured if we got the system working so well where we can have thousands of people get a beverage for a person, why can't we make it work so people have been taken care of properly? This is getting fairly long, so I'll wrap it up here. Moral of the story is Australia actually takes horrendous care of most people that need care. Thanks for watching. Subscribe. Have a good one.